Welcome, everyone, to Silver Hill Hospital Grand Rounds. We will give folks just a moment to join as you all come online, and then we will get started. Hello, everybody, and welcome to Silver Hill Hospital Grand Rounds. It's wonderful to see so many of you joining today. And as you log in today, I'm going to get started because we have really a wonderful program today, and I couldn't be more excited about our speaker today, Kelly Posner, speaking on such an important topic of suicide assessment. I'm Andrew Gerber, President and Medical Director at Silver Hill Hospital, and I am standing in today for Dr. Jeff Katzman, our Director of Education, while he is off in San Francisco presenting at the American Psychiatric Association. I could not be more delighted to welcome Dr. Kelly Posner, presenting on the topic, Saving Lives of Individuals, Their Families, and Communities with the Columbia Protocol, an all-hands policy tool, reducing suicide, redirecting resources, and reducing liability. And while that may be a long title, I promise you that this is a talk that delivers on all that promise. Before I tell you a little bit about Kelly, I want to do a little bit of housekeeping. Our next Grand Rounds will take place on June 14th, where we will welcome Dr. Andrew Chambers, speaking on translational neuroscience of addiction psychiatry, from rats to the 2x4 model. I hope you'll join us on June 14th. But back to today's lecture. Your questions are an important part of our Grand Rounds. I'm joined today by our Chief Clinical Officer, Dr. Michael Grote, and he and I will moderate the Q&A discussion with Dr. Posner at the end of her lecture. So I hope you'll stay tuned all the way till the end, because the questions are an important part of this process. It's your opportunity to put forward questions and comments and get responses. You can submit a question anytime during the lecture by using the Q&A box, either with your name or, if you prefer, anonymously. I think a lot of people find that writing the questions down while they're on their mind is helpful, and we'll come back to those at the end. So please feel free to post them anytime. A key component of Grand Rounds is providing no-cost continuing education credits. We are delighted to inform you that Silver Hill Hospital has been approved by New York State Education Department, the New York State Education Department State Board for Psychology, to provide continuing education for licensed psychologists in New York. If you wish to receive CME, CEU, or contact hours, please kindly complete the evaluation survey that will automatically show in your browser when we end the webinar. We will also email a copy of the survey to today's participants. And finally, disclosures. No planners of this activity have indicated a relevant financial relationship with an ACCME defined ineligible company whose primary business is producing, marketing, selling, reselling, or distributing healthcare products used by or on patients. I apologize for all the gobbledygook, but these are required statements. It is now my great pleasure and honor to introduce our guest speaker today, Dr. Kelly Posner Gerstenhaber. This is not your typical introduction. So if you're used to tuning out during intros because they tell you where they went to school or this or that, pay attention to this one, because you're never going to hear one like this again. Dr. Kelly Posner Gerstenhaber is a professor of psychiatry at Columbia University. The former president of the American Psychiatric Association noted her work with the CSSRS, which you'll be hearing about today, could be like the introduction of antibiotics, and I quote. The U.S. Department of Defense said her work is nothing short of a miracle, and that her, again, quote, her effective model of improving the world will help propel us closer to a world without suicide. These are not people who tend to exaggerate, and this is what they said. The CDC noted that her work is changing the paradigm in suicide risk assessment in the US and worldwide. Dr. Posner's work has been noted in a keynote speech at the White House and in congressional hearings, and she gave the lead presentation in a US Senate forum on school safety after Parkland. The White House recently highlighted the Columbia Protocol app as helping to achieve the president's mental health and suicide prevention initiatives. Jim Shelton, former Deputy Secretary of the U.S. Department of Education, says her work, and I quote, has the potential to keep the 64 million children in our schools safe physically and mentally by helping prevent school violence. Leadership of Israel's National Suicide Prevention Program articulated her work's impact. It's not only saving millions of lives, but in Israel, it is literally changing the way we live our lives. Through her advocacy, she has helped change local, national, and international policy, which in turn has contributed to reductions in suicide across all sectors of society. The CSSRS is policy across all 50 states, national agencies, and most countries. The FDA has characterized her work as setting a standard in the field, and a lead article in the New York Times called it one of the most profound changes of the past 16 years to regulations. Dr. Posner gave the invited presentation on tackling depression and suicide at the first European Union high-level conference on mental health and was recognized as the most distinguished alumna of her graduate school at Yeshiva University over the past 50 years since its inception. Her scholarly work has been included in the compendium of the most important research in the history of the study of suicide and was recognized as one of the top 20 most influential scientists from Columbia University across all areas of medicine over the past 10 years. And I'll add parenthetically, that includes 2 other Nobel Prize winners, by the way. Dr. Posner has been awarded with the Secretary of Defense Medal for exceptional public service. On a personal note, I've had the enormous privilege of being Dr. Posner's colleague in the Columbia Department of Psychiatry and Division of Child and Adolescent Psychiatry since 2005. She is a generous and generative colleague who has been a resource to me throughout our time in the department together and to countless other members of the department. You may sometimes hear people say that at academic departments, you only get to know your colleagues outside of the institution when you go to a conference or when you hear from somebody else. But that could not be less true about Kelly. She is beloved at Columbia as a friend, colleague, and her achievements have raised the level of scholarship and clinical care throughout the department and Division of Child and Adolescent Psychiatry. I could not be more grateful to Kelly for her work and personally for coming today and presenting to all of us. I'm proud to call her a friend and colleague. On that note, I'm going to turn it over to you, Kelly, and look forward to your wonderful talk.
Thank you, my friend. I am equally grateful for this long-term partnership with your system and with you. I also wanted to note to that bio, I also had 4 kids in 5 years for all those multitaskers on the call. So let me start by saying that this isn't a problem of veterans, of the elderly, of children. This is our shared crisis of humanity. But the very good news is that it's our one preventable cause of death, despite the fact that it's been this tragic paradox that takes more firemen than fire, more police than crime, more lives than car accidents. So I said it's preventable. Let me tell you the good news, or so we thought. After 20 years of the suicide rate going up each and every year, in 2019 and 20, we had our first reductions, even during COVID, 6%. But here's the big caveat. That reduction was only among white Americans. Where we still were seeing crisis was among our most vulnerable and minorities. And now, sadly, it's gone up again, 4%. And the largest accounting for that increase is males 15 to 24. And I will talk a lot about that help-seeking barrier and stigma that takes lives particularly potently among men and boys. So number 1 cause of death in adolescent girls across the globe, second leading cause of death in 10 to 24-year-olds. And remember I said minorities is where the crisis, get this. The CDC has told us that 5-year-old suicide has increased, but only among African-American preschoolers. It's now the leading cause of death in Asian American Pacific Islanders 15 to 24. So we've seen this intersection between these 2 humanitarian crises, right? The racial unrest and instability and the suicide crisis. So a few years ago, there was a young man found hanging in one of our parks. And this was mimicked across other states in the nation. And at first they thought it might be a lynching, but then they realized it was a suicide. So the Department of Human Rights in New York City called me and said, Dr. Posner, how can we help this community? And one of the ways that we can help these communities are by better detection and education. And we know that it touches everyone. 135 people are affected by every death. And these effects linger across generations because of the silence that often follows. I should have told you that for every depressing statistic, we have a very hopeful counterpart. But when you think about this, 123 lives per day times 135, the ripple effect is almost unimaginable. And this silence and shame across generations is not unique to our nation. It's every nation. I work with most nations, and Ukraine, priests won't even bury you because of the consequences. World Health Organization shows that religious countries that condemn suicide, right, they don't report, they have lower rates because they're afraid to report because of the consequences. So we had a signing ceremony with the Kingdom of Saudi Arabia, very exciting and very symbolic of everyone, everywhere. It was an all-female university that said, we want to bring the Columbia Protocol to all Arab citizens. And they said what it was like to even admit that we have a problem in our nation. What a big step. And this is helping bring us into the light. So I was very excited about this full-page editorial in the Tennessean, "Hope at Last to Break Suicide Silence." I was excited until I read the blogs on the newspaper's website. A leading cause of death, I have my doubts, maybe in some third world or oppressed countries or among some teenagers, but certainly not in the United States. Hope at Last to Break Suicide Silence. I was not aware there was any. And that was from a retired mental health editor of all people. So I always say that even if we're not identifying in a better way, which I am certain we are, the fact that we're having these national conversations is so critical. After, my important paper came out, somebody called up and said, they were talking about it on Howard Stern. I'm like, yeah, tell me another one. But they were, and that's important. These conversations need to be front and center. So, the Columbia, you'll see, is policy across the continuum of care, across all states. But one of its most important reasons for being now is a vital part of health and wellness for employees and their families. Did you know that if you take a large corporation of 100,000 employees, every 6 days, an employee or a family member will die by suicide? Every single day, there will be 3 suicide attempts. So at my system at Columbia, I give the first 5 minutes of every safety update before washing hands, right? And if you look across, I'm going to get to that in a second. If you look across these 50 states, when the policeman or fireman is doing it, they're not just doing it in their job. They're doing it to save their own lives. So you see, this is an example out of Texas. They use it to screen civilians, very important, to identify members in the department and recognize family members. And it doesn't matter what front line you're talking about. This is how it's used. So I went on CNN a bit into COVID, and American Medical Association called me up and said, yes, of course we know the Columbia, but how do we get it in all medical professionals' hands? So you guys can see on your phones, there's an app that people use all the time. We hear stories, the head of DHS workforce, I lost 4 people. I use it as a self-check every day. And Department of Homeland Security has their own app. So if you're Secret Service or TSA, it connects to their EAPs. But the reason I'm bringing it up is because the commentary, the articles around this is how we take care of our employees, just like we do nutrition and physical fitness. And when you treat this like wellness, boy, that helps you save lives even more. And it also says, and their kids, right? Employees and their kids. I went to Sloan Kettering to give a talk because, as you know, it's like blood pressure most places. And the head of nursing said, I used it to save my son's life. And we hear that 1,000 times over. So what I'm sharing today is really about saving the lives of the workforce, your patients, communities, kids, and families, which is very exciting. So you guys know that in September, there was a Physician Prevention Awareness Day. And that day at Columbia Cornell, all 10,000 residents got these cards. Ask your fellow resident, care for your fellow resident, ask your colleague, with the particular EAP numbers on the back, and on the back of the lanyard Everybody, no matter what area of medicine. Did you know that it's often the number one cause of death for male medical residents, for nurses? And this is really a vital part of the solution. So look what we did here. Every person that worked in your hospital can get this. Silver Hill, ask your resident, ask your colleague. It has your EAP number on the back, et cetera. And we're going to send these all to you so we can really help care for the community and all other people. I know there are Yale people on. This is now being presented to, Yale, New Haven for the EAP. So everybody can get this. It's very life-saving, low-hanging fruit. And also families. So this is an example out of Homeland Security. They give it to the EAPs that care for families like dog walking and childcare. Again, what your communities and system can do. And we know how important this is. Healthcare workers often feel this obligation to appear healthy or invincible and may be hesitant to ask for help. And doctors are particularly less likely to seek help. And human service workers, which all of you are vulnerable, all of us are, to compassion fatigue, et cetera. And we know that coworkers are uniquely positioned to help save a life. And when we promote help seeking, oh my God, that helps us lower suicide in the workforce. And we just know that, like black and white. So I'm going to shift to guns for a minute. You know that 2/3 of gun deaths are suicides. And I always say that guy who goes up to that gun counter to buy that gun does not want to die and does not know there's help. Nor does that gun shop worker want to sell the gun to somebody who's going to hurt themselves or somebody else. So that gun shop worker is not going to ask the Columbia at every person, every contact, like you would do in primary care. But if he has something feels off, somebody won't answer the question about why they're buying the gun, he will have a tool and wants a tool to be able to be helpful and divert a tragedy. So we've been working with the gun community for a decade, right? You can see people put it around the gun locks, et cetera. And how does it connect to mass violence, right? Why did President Obama's deputy secretary say that this can keep our 64 million children safe? Because 90% of shooters have suicidal issues. So I said this back at Columbine, screen, and perhaps we'll be able to find people before it's too late. So it's just a way to detect them. So if you recall, in a bit into COVID, we had 2 mass shootings in one weekend, one on Saturday, one on Sunday. So the CNN town hall said that the Columbia Protocol is the highest form of see something, say something. And look at how else it's used to help address the gun crisis. So this is Connecticut, by the way, shout out to your state, really leading the way. So in much of Connecticut police, they actually have the Columbia in part of their risk protection orders to identify who should get a gun license, who should have their gun taken away. And that's so, so, so important. And, how does it connect? Why are they able to do that? And why is the Columbia pretty much the global common data method? Well, one of the big reasons is that it's the first time we have evidence-based thresholds for who's at imminent risk. This has been an elusive goal in the field that we have not been able to actually accomplish. But that's what the massive science between the Columbia does, right? And that's really, really important. Identification of high risk for the first time. And what's so important about this also, only about 1% of people get a high risk answer. And what happened in the past is that the policemen had to take everybody to the hospital because they didn't know who to worry about. Everybody had to be put in that ED hold room. My first call with Joint Commission, who now says, use this and why, they said, oh my God, this is going to be so helpful in reducing those unnecessary ED holds. And by the way, do you know what happens when you take somebody to the hospital that doesn't need to be taken, or you put somebody in the ED hold room who doesn't need that level of intervention? It shuts that person down from treatment when they actually need it. and it's traumatizing, right? But it really prevents future care. So when you treat moderate risk or low risk like high risk, you actually undermine your ability to care for the people and detect the people who are at high risk. So that app, we've done yeoman's work with many states on really perfecting the app. And you can see on the app, if you get a low or moderate answer, it says a mental health referral may be helpful. It doesn't treat it like crisis, right? It doesn't treat it like high risk, and that's really important. And so what this does is actually redirecting a tremendous amount of resources, no matter what kind of resource you're looking at. So these are one-to-ones, for example. I'll never forget, this hospital said, we had 20 one-to-ones indicated, but we didn't have 20 people to watch them. So before the Columbia, it was like playing Russian roulette. So you'll see massive science, 600 studies, 50 predictive, but the icing on the science cake, which you're going to love to hear, the ERs out of Sweden, using the screener with the evidence-based thresholds, it predicted death by suicide. That has never happened in the field before, ever. Just reinforcing the great work that we're all doing with these questions. Why did the former APA head call it the next antibiotic potentially? Because, we've made, massive improvements in mortality and all these other diseases, but not suicide, because of stigma and a lack of a ready, easy to use method by which to detect it and then take action to prevent it. So I want to give you the scope, by the way. Do you know, I sometimes I say this at the beginning, what do you think the number one cause of global disability? It's depression, not cancer, not heart disease, etc. Costs humanity more than anything. So at any one point, at least 10% of the globe will have depression or a serious mental illness. 20% of teens meet criteria for depression. I used to be the head of diagnostics as well, so I'm, a walking DSM, but look at that scope, and that's in normal times. We know now, during COVID and other times, it goes up tremendously, and nobody is spared, meaning we have to care and detect and screen everybody. After 9/11, preschoolers who weren't even directly affected had up to 8 months of symptoms. And bringing this point home in terms of what it costs us, get these numbers. 264 million people are living with depression, compared to 18 million with cancer. And here's the good news and the bad news. The CDC has told us, unbelievably, that we are the only developed nation in the world where the life expectancy is going in the wrong direction. It's not going up, it's going down. And we don't have a cure for cancer, and we don't have a cure for heart disease, but we do actually know how to cure this. And I don't need to, doesn't discriminate rich, poor, black, white, celebrity, or teacher. I said this is our preventable cause of death. Why have we been struggling? Well, one of the reasons is that it's been the most devastatingly under-recognized and underfunded issues. Until a few years ago, NIH spent more money on the West Nile virus, which takes 137 lives per year, than suicide prevention. Look at those numbers down there, 37 million in suicide prevention versus 6.6 billion in cancer. Remember that 264 versus 16? Unbelievable, the discrepancy. So the good news is we're making progress. Now all 50 states have introduced bills in the past year on suicide prevention, more than the past 3 years combined, but we still have a lot of work to do. So this is one of the most helpful and important things I can tell you. The high cost of not screening as upstream as possible. And when we're talking about suicide, it's not about money. But when you're putting all your resources in the wrong direction, you can't do what you need to do to save lives. $300 billion in years life disabled or lost. This is a major renowned colleague, Dr. Gibbons, in a general ED in Colorado, 400% increases in hospitalizations prior to this, 300% increases in ED visits. What happens when you start to do something about it? Look at this. Centerstone is the largest provider of outpatient community healthcare in the United States. They reduced suicide 65% in the first 20 months in just one state, while they reduced ED recidivism from 40% to 7%. You're going to hear a lot of examples about millions of dollars being saved, et cetera. And I'm going to keep saying it's not about the money saving. It's about when you have all that noise, the 40% versus 7%, you can't do what you need to do to help save lives. And all these great examples reinforcing this work. Atrium Health across 2 states, 1 year, 50% reduction in suicide, 86% reduction in the behavioral health service line. And it doesn't matter what caregiver you're talking about. This is so important. Years ago, Alaska called me up and said, my God, we have to send a policeman 3 hours out into the middle of the nowhere, 3 hours back, who never needed to go to that call in the first place, right? Takes 6 hours away from his ability to fight crime. Again, these redirecting of vital resources is so, so critical. And I know this will resonate with you too. This was a study out of New York. 61 to 97% of student referrals do not require hospitalization. The great majority of kids and teens referred by schools for psyche or eval or not hospitalized do not require the level of containment, cost, and care entailed in that. And evaluation in hospital-based psyche is costly, traumatic to kids and families, and less effective in getting them where they need to go. I always used to focus on the benefit to the system. One state leader said, what about these families who don't have enough money to pay for the care they actually need? And I talked to you about the traumatization, and this is schools. This was out of Tennessee when it became the crisis assessment tool. They said, the kids sitting in the principal's office for 9 hours waiting for the EMT to get there who never needed to be sitting there in the first place. Okay, so watch this video.
We received a 911 call from a woman named Joan who said she was upset and afraid she might kill herself. So I was dispatched to her location. I've been in situations like this where it was really hard to tell if someone was actually in danger of suicide or not. Fortunately, I was recently introduced to the SSRS, and I could question side what level of care she needs. I'm glad you told us some help.
Okay.
Your thoughts, behaviors over the past 2 weeks help us better understand how to help you. Is that okay?
Okay. The hospital.
Let's pull the information, what's going on first, and then we can talk about that. All right?
Okay.
Good. Have you heard Dad wished you could go to sleep?
Yeah. I wish I was dead.
Have you asked about killing yourself?
No, I would never do that.
Have you started to do anything or to do anything to your life?
I mean, when I was a teenager, I wanted it, but not recently.
Okay, thanks.
That guy's actually a law and order actor, I think, but he actually did a pretty good job. And that young woman definitely needs a referral for treatment, but she doesn't need to be taken to the ED or the ED hold room where she's just going to be sent away and probably traumatized. And what happens is what New York State said when it first went to every behavioral health contact is what's really nice is that it's proscriptive enough for the non-professional, the ED triage nurse, the policeman, but yet flexible enough to just inform a clinician's judgment. So that policeman had a proscriptive formula. She had a wish to die, which is the lowest risk answer. She had a behavior many years ago, which is moderate risk, definitely not high risk. So he knew what to do with this young woman. And by the way, do you think that policeman wants to take somebody unnecessarily? Absolutely not. And now you'll see how the liability protection allows them to actually do the job they need to do. And so this is out of Connecticut, who've really done yeoman's work as a model for the globe. So most police in Connecticut, you'll see in a few minutes, have this little sticky pad with the Columbia on it, and it connects to Connecticut resources. And they've talked about all these benefits. I'm talking about the redirection of resources, right? They said it's actually been reducing level of force, right? Because if you're having fewer calls, fewer people going back and back to the ED, right? You have less need for that. They also talk about, because now they have a tool to help them know who needs to be taken to the hospital. They also, this secondary gain, they also spoke about it as a de-escalation tool, right? Parents are saying, no, 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 your officer says, okay, I understand, but maybe we can go through these questions, and it really allows you to de-escalate. And I was thinking earlier before I got in this call, just like when you want to put somebody in a hold, or you're in one of those situations, this can actually work that way to de-escalate. And it's a nice thing to think about. You know, Cherokee Nation actually articulated this very well, that its ability for risk stratification helps you improve access to services. You're able to triage your wait list better. So you know that 1% of people who need whatever they need right now. And I'm not just talking about behavioral health. I'm talking about, you know, food banks, transportation, whatever it may be. And I told you it's not about the millions of dollars, but look at this. Oklahoma, they've now saved millions of dollars in reduction of days in bed days. And I don't need to tell you, you know, the irony of the time of greatest risk is when somebody gets out of the psych hospital. So you avoid all those unnecessary sequelae. And the other thing I want to mention here, I'm going to tell you a story, okay? I was giving a talk many, many, many years ago in Connecticut at the National Guard for the state. And this huge system said, you know, we gave it to the janitors. And this clinician from the VA said, exactly right. I'll never forget that case where the only person that vet spoke to was the janitor. And it doesn't mean he's ever going to need to ask these questions, but if it will be helpful, he will be prepared to, you know, so you can see this. And, you know, Vermont has policy for janitors and front desk staff workers. I'll tell you, you know, another, I'm getting ahead of myself, but another Connecticut story. A front desk staff worker in a hospital saw somebody not looking good, knew it was okay to ask. He disclosed writing a note, which only the Columbia gets you, and he got taken to the hospital. So you can see all hands, every single person within the walls of your system and outside the walls of your system can and should be part of the solution. So you can see Cherokee, custodial staff, sanitation, dock workers, cafeteria. I'm going to tell you this other story, again, ahead of myself. I went to Jackson, which is a huge system, to give them a talk last week. And somebody said, you know, that this engineer was fixing a light bulb in the patient's room, and the patient started talking to him. He knew about the Columbia. He asked, the guy fixing the light bulb potentially helped save a life. So you remember I said Centerstone 65% in the last 20 months? They brought that to life by telling a story about this guy who they called a few times and he said he was fine. He said, the last time you called me and asked me those questions, I was on the bridge. The power and importance of asking beyond the doctor's office. So that young woman, right, operator, is in the setting, right? Imagine in your setting, but somebody doesn't show up for a visit. She calls, tries to track them down until they find them on the bridge. When you're thinking about delivery of the CSSRS, you want to really think about that potency and importance of detecting and asking well beyond your office. And this is great science supporting what we talked about. This was out of Magellan. You know what they found? When EMTs do it, it increases voluntary hospitalization. That's what we want, right? This is big screening out of the VA. Look at this. Universal screening with the Columbia led to improved mental health follow-up and treatment engagement. It engages them in treatment more just by screening, and by 60%. Okay, and this was the Magellan study, right? What this does is crisis services meet individuals where they are. And that's what we all talk about in the nation all the time, that is most beneficial to saving lives and to the system. So I've been talking about this need for the public health approach, but I want to really bring this home for a minute about why this is so important. Did you know that 75% of people in the United States who take their lives do it in their homes? 95% of 5 to 11-year-old Black children who kill themselves, as an example, do it at home. So we need to get into every home, every family member's pockets, et cetera. And my co-director, Dr. Keita Franklin, was head of suicide prevention for Department of Defense and Departments of Veterans Affairs. And she really showed for the world what we needed to do to move the needle, which was have a public health approach to find people where they work, live, thrive, and learn, because many never get to the doctor. So you can see in the corner, that was an urgent memo out of the Pentagon saying that we must put the Columbia in all hands because people don't get to the doctor. And this is what communities all over the globe are modeling. And so, I already told you the light bulb story, but it really brings the point home. This was, somebody in the Marines said, people don't go to leadership, bartenders, barber, at the gym with trainer. Every single aspect of the community can and should be part of the solution. And like in Montana, it's literally frontier. It's literally frontier, let alone anything else. So the state has invested a few $1 million. They do universal screening in the schools, and they get same-day intervention. So it's proactive instead of reactive. And every single screening has identified more than one kid who wasn't known to have mental health issues. Okay, this is also one of the most important concepts that I can share with you. You probably know that over 50% of people who die by suicide have seen their primary care doctor the month before they die. If we don't treat this like a vital sign, like blood pressure or vision testing, we will not find the people suffering in silence. Did you know that 2/3 of adolescents who show up to the ER who've tried to take their own lives are not there for psychiatric reasons? Okay, but here's the big take home as well. We have to have this concept well beyond the doctor, as I keep saying, because many people never get to the doctor. So I like this example. It's the #1 cause of death in construction workers very often. So the unions say, let's have the safety check in the morning be more than the hard hat. Let's have it be the Columbia. Every state has policy in schools, and actually in Connecticut, it's going to be legislated. Now, teachers are approached, et cetera, as upstream as we can get. So you have that concept generally. And then when there's a time of increased risk, like when you're transitioning from active duty to veteran status, you're an injured baseball player, you have a mass shooting, war in Ukraine, you can get even more hypervigilant about that. And guess what? This won't surprise you. When we do this, treat it routinely, it actually destigmatizes. And people, clinicians, or anybody asking and people being asked actually feel more comfortable. This is out of, a hospital system. Okay, so this is another video. This is the VP of disaster management for Centerstone.
Now, in terms of screening tool, it's we use their screening questions. It's embedded to our and every service. And if there's every them, they're gonna, and we just keep people no harm, no foul. Everybody ask it all the time, and we really act like it's standard operating procedure. Just like when my mom got by a spider last summer and went to the ER, and they asked her if anybody in the house hits her. It's just a law in Tennessee, and you have to do that. And people seem to be okay with that. If they answer no, move on. Pop up and say they're not recommended to go in the pathway. Our staff can override that if they feel hinky about it. That's a southern, well, it's not a southern word, it's just my word. If they feel, if they like, clinically, I think they need to be, they can override it and still put them in it. If they're positively, then the full out assessment pops up and they go through and they complete that. And again, the box will pop up and say yes or no. It's really thrilled with the authors of that tool and said, which questions would you think would that told us program that way? Our staff to think about what they need to ask next just pops up, and our programmers did that for us. So it's a pretty simple tool that way. The staff like it, and they enjoy function way based Columbia education. And you can't go any further until you go, and they and you all create, modify a crisis, or let you go further. Our two are mandatory. So fidelity. We created reports off of that, and one of the reports lets you know when people are overridden, because it can recommend you go in the pathway and you can override it and not put them in. But we created a report that shows us why they overrode it. The first time I pulled it, I almost fell out of my chair. I what? Patient didn't need to be in the pathway because they just got out of the psych hospital. Patient, and I'm paraphrasing this one a little bit, but not much. Patient doesn't need to be in the pathway. She's a borderline personality. So that is us having to own our staff are not educated on this and not putting any blame. And we're going to talk about that a lot later, but not putting any blame on them that they don't know this. That's on me. And that's my responsibility to make sure they understand that.
I just love watching her every single time. And what happens is there or any system, we have these well delineated, streamlined, big system alerting policies, optimizing identification of those at high risk across the continuum of care. And they said at Centerstone, with so many patients, it's like mining for gold, and Columbia is the sifter. And look at the ease of this. So if you get the 1% in a high risk answer, you go into crisis pathway, then there's a formula to take them off. That's Centerstone. If you look down in the bottom, that's New York State's EHR. It's not just the Columbia. When they get those high risk answers, the big red suicide alert arrows go off, and that travels with the patient. So if you're off the grid for 3 years and you show up at some outpatient clinic, some provider will have that information. And I can't overstate the importance of that. And these are ways that we can perfect for your own system as well. And very importantly, you can and should use this for tracking patients' improvement. Do you know one of the reasons we first created the Columbia was for efficacy and improvement? And so that's really important. You want to know if people are getting better. So, in the Army, we know that if PTSD treatment works, right, that suicidal issues should reduce, but there was never any data. So they took part of the few million Columbias they had and showed just that, and it helped them get money for treatment. Look at this. This is a ketamine study, okay? The Columbia not only picked up response, it picked up partial response. Really sensitive and really a great way for you to improve patient care. So back to guns for a minute. I said, I told you what President Obama's deputy secretary said. And, even before that, when the Navy Yard shooting happened, he called me up. He said, what is it going to take to make this ubiquitous? And we went on a show after this. He was quoted saying that. And I was on this after the school shooting, and the Orlando hostage negotiators happened to see me and at the tail end of the show and flew me down. And I said, they shouldn't have had to get lucky, right? To happen to catch the tail end. We need more policy. Fast forward to Parkland. That was when I got to give the talk to the Senate on school safety. And that guy sitting next to me in the picture, that's Ryan Petty, who is my friend and hero. He lost his daughter at Parkland. She was one of the 17 massacred that day. And you know what? They came to us for early identification. They talk about this as much as they talk about guns, because let's get ahead of it and potentially prevent a crisis before it's too late. And you may know that after a mass trauma, risk of contagion goes up. So you might recall a year after Parkland, there were some increases in suicides. And we reached 200 million people from BBC to CNN, et cetera. Them saying Parkland tragedy turned into hope with the Columbia Protocol. And one young man who was at Parkland the year prior, who was at school in Utah, college in Utah, called up Ryan after seeing one of these interviews. He said, I haven't been able to function. Ryan did the Columbia, he was high risk. They called the crisis line together. He didn't give him the number and hang up. He called with him, he was high risk. And you know what? From Parkland, Florida, he took his phone and called an Uber to pick up this young man at his dorm in Utah and bring him to the hospital. I tell you that story. Did you hear the simple life-saving potency of that, right? And that can be a thousand times over. So when I gave that lead presentation to the Senate, I said to these senators, like, you all have policy for the doctor and often the policeman. How do we get it in every parent, every teacher, every coach's hands before if they ever get to the doctor, right? And we knew before any of this that, the CDC had data that, 10 to 12% of your average high schooler said they've tried to take their own life in the last year. And we knew that those were gross underestimates before we had better, more comprehensive monitoring. We also knew at the beginning of COVID, when parents wouldn't want to bring their kids to the ER, even with a high fever, because it might be literally lethal, they couldn't help it when it came to mental health issues. And you may be familiar with this data now. ED presentation of girls 12 to 17 has gone up 50% recently. And maybe that's good. Maybe that's help seeking. But guess what the number is for boys? Only 4%. Remember that help seeking barrier and stigma that really ends up, threatening the lives of boys and men. So when I'm working with all these states, like I said, most states, this is an example in New York State, right? You see the Columbia, but my implementation and policy work is how do we get in every parent's pocket, PTA meetings, going home, on the app, whatever it is, that's how we're going to save people's lives even more. Okay, so I'm going to tell you another story. This is Kim Ruoko, who was the spokesperson for the Tragedy Assistance Program, which is, if you've lost your life serving our nation, they take care of the family members. And she tells a story. Her husband was a Marine pilot who had untreated depression. He finally went to his commanding officer, who was empathic. He said, we've been there, all been there. Take time, take care of yourself. But whatever you do, don't go on treatment and don't go on medication, because you cannot do that and fly. And now he's no longer alive. But the point of this story right now, besides the stigma of depression, is that he was supposed to come home on leave in 2 days, and something in her gut told her to get on that red eye. And when she got there, it was too late. And she said, if only I had had the Columbia, I would have known not to leave him alone in that hotel room that night. At least she would have had a better chance. So now standardly, whether you're an orthopedic doctor at Columbia or United Steelworker or a patient, they get these questions. Ask your spouse, care for your spouse. every patient in your hospital, you should give that card, right, to their family members, because that is the first vital line of prevention. You know, the airlines brought me out to give it to the pilots and the flight attendants. And one major airline had 8 suicides in 15 months. These are not the pilots flying your planes. These are the pilots out on disability that have the same issues that everybody does. And, you know, it used to be, and up until a few years ago, that you could not have depression and keep your license. You could have every other kind of medical illness, get checked, etc. Now there are 5 medicines, so they're making progress, but there's a lot more progress to make. So why didn't people want to ask? Well, first of all, they didn't know what questions to ask. They didn't know what to do with the answers. They didn't know if it would be harmful. You know, all that clinical lore that it's going to cause somebody to be suicidal. It's actually the opposite. Asking, screening actually reduces distress. When people are suffering, they want help, right? So one of the authors on the Columbia, Dr. Madeline Gould, has a seminal article in JAMA showing that when you ask youth, it not only doesn't increase suicidal ideation, it actually reduces distress. But the other huge one was liability, right? We don't have a perfect formula. We may never have a perfect formula. How can I ask? So malpractice attorneys have written for many years that if you use the Columbia, you get protected because we've never had this much science, and you have a responsibility to ask. You don't get into trouble for a bad outcome. You get into trouble for not doing something. And, you know, the Navy non-mental health providers also made this important point that it helps with the internal liability, that at least you knew you did everything you could. And I want to tell you, so, and this is what I said, like science, 600 studies that support it. You know, if you Google Scholar, 9,000 would come up, 50 predictive, all over the globe. And the liability protection is not just in healthcare. But I will say that I think the way we think about it now is that it's minimum standard of care. Again, if you're not doing it, it sets you up. But look at this, so exciting, all over. When MIT had a suicide, like every university does, the Supreme Court brief wrote about the Columbia as the reasonable measure. And what I say is that frees up the parent, the roommate, the teacher to be able to ask without that liability barrier. Look at this. They actually put in the Supreme Court brief those high-risk answers. You see that? 4, 5, and 6. I'm going to also tell you another story right now. I was helping an unnamed Ivy League with a case. A family was suing them for a suicide. They were also suing Amazon for giving them providing the cyanide. And, you know, the case was thrown out. It was pretty, you know, easy to do that. But the story, right? This young woman, her roommate walked in, got up. She was fully made up at 6 a.m. in the morning because she knew she was going to kill herself and wanted to look presentable. And this roommate, like something in her gut, but maybe if she had had this tool, the resident advisor, et cetera, she might have a better chance. And this liability protection from the Supreme Court, that helps again, have that not be a barrier at all. And this, I keep saying Connecticut has done yeoman's work, right? This is a document out of Connecticut, indispensable added protection against liability. So that officer can actually do the job that he wants and needs to do. Okay, suicide can be prevented, never in those truly intent on suicide, sometimes, but only in advance of acute risk, always, but only in advance of acute risk, or always even up until the last moment. Always even up until the last moment. You know, there's also all that clinical lore out there that if somebody has their head set on suicide, there's nothing you can do. It's actually the opposite. 93% of people where you intervene in that moment of crisis will never go on to try again. So I want to tell you another story. You know, I love my stories to punctuate this story. My friend Kevin Hines, who some of you may have heard of, he is a CNN hero, a general hero. He survived jumping off the Golden Gate Bridge. And he tells a story, which is fatal 99% of the time. And he tells a story, age 19, woke up and said, if just one person asks me if I'm okay, I won't do it. Gets on the bus to the Golden Gate Bridge, 100 people crying profusely. What's wrong with that kid? Bus driver shoos him off, goes to the side of the bridge with policemen like riding their bikes by supposed to spot jumpers. And finally, this woman walks towards him and he becomes hopeful. And she says, can you take my picture? Forgive my horrific German accent, but 5 times she asked him to take her picture. And he said, screw this, nobody cares. And he jumped. And like every other survivor, all he wanted to do was survive and realize that all of the problems in his life were fixable, except the fact that he just jumped. And he's then gets down in the water. Well, first I want to say, he says this, right? People considering suicide want someone to save them. What we need is a culture where no one is afraid to ask. So he gets down in the water and realizes he's alive and feels something slimy. And he says, oh my goodness, I just survived jumping off the Golden Gate Bridge and now I'm going to get eaten by a shark. Just my luck. You know, you have to find a little humor in this work. And he was on a show a few months later and somebody called in and said, oh my God, I'm so happy you're alive. I was standing next to you. But let me tell you, buddy, it wasn't a shark. It was a sea lion that kept him afloat. He was meant to tell this story. You know, we work with every agency, and I was on the phone with the head of a sex trafficking agency. And she said, you know, I was a victim of sex trafficking. And I can't tell you the humanity that was taken from us. And I tried to take my own life. And I believe if we had had this, I wouldn't have. I only tell you that because people desperately want to be asked. And it's just so important to keep remembering. And we have to have that concept. Like Kevin said, if just one person asked me, everywhere there's access to means. You know, California said years ago, the transit workers, I hope soon enough you see it in the CVS. In China, pesticides are the #1 method. So I hope it's going to be around the pesticide canister. You'll see that I work with parks and they use it across the nation to save the lives of the visitors as well as the rangers. But that's a ledge where you can jump off the Grand Canyon. I hope soon enough you're going to see that little card as upstream as possible in every bathroom. Remember, you used to say, like, don't forget to wash your hands. TSA, I told you, uses it. A TSA worker killed himself in the airport, right? Who knows if we had those signs. The Miami Herald called me up because these kids, 2 kids jumped off the roof of the school buildings. And they called up and the state said, yeah, we use the Columbia, I guess, in the nurse's office, whatever, but you got to get more upstream, maybe on the roof or in the bathroom, etc. And wherever you're talking about, you have this full-on upstream public health. So this is an example in parks, right? Somebody drove off the Natchez Trace Parkway in Nashville. So the rest stop, the donkey, the person on giving you the tour, you know, the trail guide, etc. And as I said, they use it also to save the lives of the workforce and the rangers. So when I went to the Interior Ministry to give this to parks, this guy from California got up there and said, this just saved the life of my ranger. This is not a statistic. This is actually what's happening. And I want to work with Connecticut, you know, and the surrounding states to really optimize with parks as well. So this is what all 50 states look like pretty much, right? And years ago, you know, when it became the crisis assessment tool in Tennessee, they said, you know, it's so important that the school is doing the same thing as the EMT as the hospital. That quickens care. But look at this, Connecticut, I'm not just saying this to make you feel good. This is the truth. Connecticut is the model informing the globe. I told you that policeman often has that sticky pad that connects to the QR code connects to Connecticut resources. Listen to this example off of Zero Suicide, right? 4th grader sent to mobile crisis, confirms the Columbia, gets to the hospital, gets safety planning and whatever other interventions, and this more timely intervention and continuity of care. was dependent upon each touch point using this common method of detection across the state. You know, in Florida, Governor DeSantis has a school safety law, and we would get all these Google alerts from the states, from the school district saying, like, we're in compliance because all systems use it. And, you know, that linking of systems and common language is I just can't overstate the importance of that. And state after state after state has said, since doing this, we've lowered suicide. Why? Why? Because it's connecting the right people to the care they need, right? Medicaid reimbursement was contingent upon it, et cetera, et cetera. And whatever constituency you're talking about, we have this concept, find them where they work, live, and thrive. How do you find veterans where they work, live, and thrive? New York's going to give it to the van drivers, the CrossFit vans, et cetera, benefits workers. After a VA attorney used the Columbia to help save the life of a suicidal client, the Office of General Counsel made it scalable. Let's give it to everybody. And you know also how when veterans transition from active duty, they lose their sense of purpose. So veterans are giving it to all students, right? And that gives them a new way, a renewed sense of saving lives. So we can do this at Yale and all the University of Connecticut and all the surrounding, universities. And again, it just synergistically helps you, improve quality of life and save lives at the same time. And this linking of systems across the states, across the continuum of care, is also what is going on in most nations. And, across, in Israel, every school, every city for many years. And what happens is a nation takes a problem, they do a study to address it. In New Zealand, they said, of course, we have to use this to monitor parolees. They did a study, corrections officers were effectively able to identify. And what this massive global scientific foundation does, this is the foundation fueling and protecting and propelling your important public health and clinical work. This is another example. Chile identifies this problem given the high rates of suicide in adolescents and the reluctance to seek help, developing proactive, effective strategies to timely detect individuals at high risk in non-clinical contexts is a worldwide recognized need. They do a study, again, supporting that massive, adding to that massive scientific foundation. Okay, suicide is a choice, a sign of psychological weakness, akin to murder, akin to cancer, all of the above. It doesn't matter who I'm talking to. Most often I get a choice or all of the above. No, suicide is not a choice. Its biggest cause is this heritable, treatable mental illness called depression. But we don't think of depression like we think of cancer, right? You would never hear the word choice when it comes to cancer. And guess what? That misunderstanding and stigma is literally lethal. You guys know 13 Reasons, that runaway Netflix hit. What is that? What does that title say? It says the opposite. It says that this is a rational choice, not a brain-based illness. And guess what happened the month after the premiere? Suicide spiked. It can literally be lethal. What do we know? We know that antidepressants save lives, and not treating depression is what kills people. Autopsy studies are invariably associated with no treatment or lack of compliance. These are SSRIs. And since we have them, the suicide rate has lowered across the world, across ages, reversing a trend prior to their introduction. And the opioid overdose crisis, right? A lot of them are suicides. And even when they're not, there are people desperately trying to self-medicate in lieu of proper treatment. And what we know, unfortunately, however, is most people who need treatment do not get it. When I gave that talk to the leaders of the European Union, I said, 90% of people who die by suicide have a treatable mental illness, most often of which is depression. So you can put up barriers on bridges and do other things, but if you want to maximize impact, it's about treatment and identification. Up to 75% of people who need these simple life-saving medicines don't get it, okay? When the study came out that antidepressants were the #1 prescription in the country, And my quote to the media was, that's encouraging. We worry much more about under treatment than we worry about over treatment. And why? Because of stigma, right? This isn't a real illness. I'm weak if I ask for help. It's the stigma attached to admitting you have any kind of problem that gets in the way of beating depression, right? That's a New York City firefighter, ER doctors, licensing, the culture of machismo from baseball to border protection. This was a Kennedy young woman who took her life. People talk about cancer freely. Why can't we do this? And no matter where you are in the world, Namibia said, it's an abomination, depression. So what we need to do is have a culture shift where manning up is a sign of, manning up is seeking help, and seeking help is a sign of strength. So I keep talking about men. We know that men die by suicide more than women, and we used to think it was because of the methods that they chose. But Dr. Gibbons did important work. Look what he found. Only 11% of male suicides had antidepressants in their system versus 41% in females. Again, that help-seeking barrier is so much higher. What happens when you start to break down the stigma? Did you know that when you're in the Army or the military and you needed a mental health visit, you used to have to go to an outpost, and nobody would want to do that because that walk was stigmatizing. So they developed something called the Behavioral Health Data Portal, which are these kiosks which brought it inside general medicine. I'll never forget, Fort Polk, Louisiana, the provider looked at the printout towards the end of the visit. Oh my God, you have a rope in your car, you want to kill yourself, redirected her treatment plan, another life saved. And look at this, they lowered suicide. They also saved $30 to $40 million by reducing unnecessary overnights by 41%. Remember, I said it's not about the money. It's when you put people in the hospital that don't need to be there, there's a lot of risk. So this way, people use outpatient behavioral health in a much more effective way, and you avoid all that post-hospitalization struggle to reintegrate, false sense of recovery, et cetera. So the other important thing is that global bodies have said for decades that the lack of a common data element was one of our major impediments to prevention. And so the Columbia has really become that, what I like to call the blood pressure cuff. Actually, our head of the architect of zero suicide, he calls it the blood pressure cuff, and said, if you had more than one blood pressure cuff, you wouldn't know what your blood pressure means as well as you should, nor would your doctor. And this is the CDC document, right? And you can see the link to the Columbia, but also the unacceptable terms, the terms we shouldn't be using anymore. Successful suicide, completed suicide. We're trying to take the pejorative and negative connotation away, and we just say died by suicide. The other thing that's very important to know is that it's also what helps you make sense of what works and what doesn't. Remember, I said use it to monitor improvement in your patients, and that's what people are doing all over the world. The SAMHSA had said beyond its method of detection, ability to detect, we've never had such large data to show us what works and what doesn't. So look at this. This is an example. This was a new meta-analysis showing frontal lobe alterations in suicidal and depressed youth across 21 countries. And the reason they're able to do that effectively is because all those countries and research efforts use this particular tool. So these were the congressional hearings. I'm going to play this for a second.
I couldn't be more pleased to tell you that the services meet on a quarterly basis. Their suicide prevention program managers we've had 2 of those meetings so far. They share a number of best practice. I could give example. You heard in some of our implement tools like the Columbia Suicide Severity Scale or the VA Safety. They learn that from each other, and those are exciting opportunities. And I see that as the office. We've also implemented several key evidence-based suicide prevention measures, including training on the use of the Columbia Suicide Severity Rating Scale, Veterans Affairs Safety Plan to enhance risk assessment intervention. More pleased to tell you
They learn it from each other. State learns it from state, system learns it from system, neighbor learns it from neighbor. And, Joint Commission said this a long time ago. It's so important to do the same thing. When the ED is asking one thing and the social worker is asking another, you can't hone in on the needle in the haystack. This also informs regulatory policy. Intent to act is actually from the Columbia, right? So, this is the global thing. It's 150 languages, et cetera, et cetera. What is another reason that it's been chosen, right? It's the first time we have all suicidal behaviors. What does that mean? You would be lucky if you got asked about a suicide attempt and then you missed the person that bought the gun or wrote the suicide note or collected the pills, things we absolutely cannot afford to miss. But look at this science. Of the 1%, only 13% were actual suicide attempts, meaning we were missing 87% of serious suicidal behaviors. And the science is unbelievable. An interrupted attempt, when a policeman grabs somebody or you take the pills out of their hand, was 4 times as predictive as an actual suicide attempt. My goodness, right? And so preparatory behaviors is one example. Every shooter wrote a note, right? Nobody was asking about that before. Now, I keep talking about the identification, of high risk. Look at this. Do you know that the national guidance, right, is screen for depression after 12, screen for anxiety after 8, don't screen for suicide at all, as if something magically happens when you're 8 to 12 or in general, that they're just going to come show you, as if when you're monitoring for blood pressure, or for heart problems, you don't take blood pressure, right? We know we have to ask everybody, but look at this data. 6 to 12-year-olds in an ED had the same odds of being identified as high risk as 13 to 17-year-olds. And the screening did not increase ER length of stay. Look at that. Outpatient, 3.6%. So clearly, you need to screen from 5 or 6 and up. And this, I can send you, but each one of these unique items on the Columbia has so much science that supports it. And one of the things that, you probably realize is that what it does is it's 3 things in one. You screen, triage, and identify high risk all in one. And you guys know the PHQ-9. And a long time ago, people used to think, well, let's trigger in to the Columbia from the PHQ-9. Absolutely not, because what that does is give you all these false positives and miss people you need to. So Cleveland Clinic first did that. 6% got a positive screen on the Columbia versus 24% on the PHQ-9, while they found cases that would have been missed. The Air Force Family Health Clinics, 13% versus 1% at follow-up. Look at this, by the way. And item 4, which again, nothing else has and is one of the game changers, intent to act. Look at that 1,400% increase in risk. And all this, all this reduction in hospitalizations, diversions, et cetera. I'll send all of this to you. So we talked about, I've been talking a lot about the public health implementation, and, the medical model is narrow, the public health is broad, and we know what we have to do is find the right people out there so you can deliver the important care you need to the right people. So I told you the Marines were the first ones to test this. Maybe I didn't actually say that. Total force rollout, legal assistants, financial aid counselors, clergy, they reduced suicide 22%. You know what? They also reduced domestic violence, alcohol, sexual assault. The Air Force brought that to another level. They were the only service to lower suicide, spouses, dentists, et cetera, et cetera. And whatever constituency you're talking about, right? In all hands, right? In schools, peers, et cetera, et cetera. Global toolkit. And again, systems and communities actually use it to actually provide money for treatment and get resources that might be important. And one of my final points is that, that a common language is literally an intervention in and of itself. Asking can be like medicine. It builds cohesion, it builds connectedness. did you know that CDC tells us that connectedness is one of the most important things we can do to prevent suicide? And lest you doubt the importance of that, there's a study that shows that its opposite, loneliness, is equivalent to smoking 15 cigarettes a day, more lethal than heart disease or obesity. So this is actually more than just a method to identify someone at risk. It's a framework for normalizing these tough conversations and reducing the stigma. And we also know that when you're asking, that actually helps everybody heal. And the other thing I want to say is peer-to-peer. Oh my God, it's the most effective thing you can do. This is 10 EU countries, 11,000 students. Peer-to-peer was the most effective in reducing suicide attempts. And why? Because, people who do the same thing as you, they feel that only others who have been there can relate. And look what the science tells us. Look at this. Peer-to-peer increases hope, improves quality of life, reduces the use of ER, links people to resources, unbelievable all upside impact. And one of the other things that my friend from Parkland said, I don't know why it's not in all global hands. And it's because every citizen doesn't know about it. So we talk about these public health approaches, like on the side of a bus. Amazon said they might put it on the side of the box, on a billboard. And we did the same thing with seatbelts and quitting smoking. And this is the last thing I'll tell you, at one point in history, learning to wash hands began saving lives. And now doing this really can build that path of resilience that will span generations. And why did Israel say that it's changing the way they live their lives? They said by breaking down barriers that have been built up over thousands of years. So the third generation Holocaust survivor who never had a voice now does. It gives voice. And that if you can talk about suicide, you can talk about anything. And then finally, Parkland said, Major League Baseball, whoever you're talking to, as a community, we don't have to sit back and feel powerless. We can all feel like we're part of the solution. So thank you so much for that. And now we have some time for questions.
Fantastic. Kelly, what an amazing tour de force. I mean, just so much information and really inspiring to hear you. So I'm going to jump right in. The Q&A is open. Please click on the Zoom link if you want to ask a question. There's a ton of great questions already there, but please jump right in. We're gonna pick and choose and summarize a little bit. But before we do that, I want to turn it over to our Chief Clinical Officer at Silver Hill Hospital, Michael Grote, a psychologist like Kelly, and somebody who thinks a lot about, works with a lot of individuals with suicidality. Michael, I'd love for you to get us started and share.
Sure. Thank you, Andrew. And, Kelly, I just want to join Andrew in saying two things. One, this was a remarkable tour de force. And second, the accolades you are receiving and your team is receiving regarding being a transformational leader, well-deserved. I mean, this is an incredible scope of work, the way you're really transforming systems of how to think about and approach and detect people we should be worried about. Two quick things. One is you referenced, I think, extraordinarily appropriately so, the role of peer support, something that Andrew and all the people who work here at the hospital, we see the importance of the sense of connection, the sense of belonging. I'm curious to know, as people develop a shared language, as they develop a shared framework to think about a system, if it's also including, from what you can tell, conversations about what are the antecedents of why people are so disconnected and don't feel like they belong. I'm just curious to know if you've seen those kind of conversations opening up around even the upstream aspects that lead to what we're trying to detect.
Yes, I would say absolutely, right? Because when this is the center of that, and it opens up so much of that and has all that positive gain that you're talking about. But that was really nicely articulated.
Yeah. Okay, great. And then the other thing is, looking broadly at our questions, there's a number of people who, just like all of us, are in the trenches, working in busy ERs and outpatient clinics, and they're trying to think about how they develop that shared language and understanding in their teams. Any pointers for them?
Well, the good news is, right, that you don't even have to ask, right? You can give somebody in your waiting room a piece of paper to circle the screen. You know, actually at our hospital, they did a study in the waiting room to see whether people preferred being asked in the waiting room or by the clinician that they were seeing. And it was like 50-50, right? So you do what works. The receptionist can ask the questions. Everybody can. As like I said, you can build it into, you know, the little screen that they're going to do their other answer questions on, their demographics, right? It's so easy. And it not only doesn't have to take time, it actually frees up more time. But I will say that people often ask, how often do I do it? Right. And it literally is every contact. So every nursing shift, you know, Dr. Barbara Stanley, who is the author of Safety Planning,
Yeah.
and she's also an author on the Columbia, and we just lost her.
Yeah.
She just passed away.
She did. Oh.
Yeah. But she said, you know, if
Yeah.
she's one of the great interventionists, if you have time for one thing and one thing only,
Yep.
it's asking those questions, because God forbid the time you needed to ask is the time you didn't ask. And when you think about this, 2 to 5 questions that reduces all that, only 1%, right? It's an all upside solution.
Okay.
And again, and when we start to treat it like a vital sign and we normalize it, like, how are you, right?
Yes.
And take that stigma away that a lot of people and clinicians still have, it's catapulting. That's a word I've never used before, but
No, it makes sense. You're talking about, you know, building a system within whatever microcosm you work in, whereby anyone can be involved in screening and monitoring. And any thoughts on how to work with the team to get everyone on the same page about the results? Because let's say, for example, I'm a nurse and I'm working in an environment and I'm using the CSSRS and I'm finding that someone's very low risk. But another member of my team is like, well, I think we should hold on to them. And, you know, there's a whole process of how do you build kind of a trust in the tool and work as a team.
I think I'm so glad you asked the question, because remember when I said, you know, New York said it's proscriptive enough. What you have to understand is that this hugely evidence-based tool is really to triage, right? So all high risk means is that you need a further evaluation. So what that means is you're going to figure out who goes in red, who needs that next step. That can be, if you're in a home, it can be calling 988, right? It can be whoever doing a telehealth, you know, assessment. And then that provider can just have it be one piece to inform their clinical judgment. So I like to say, let's say somebody has a red answer. They had a thought with intent and plan 29 days ago. They got back together with their boyfriend. Everything's fine. You know, that person doesn't need to be hospitalized. And somebody else who has nothing on the Columbia, but has all these other high risks, right? So it's the really great combination. And it's this flexible toolkit. So when you're using it for high risk assessment, you can use the full version, which also has risk and protective factors. It has the intensity questions, which is a range from 2 to 25. When you get to a 21 to a 25, the odds ratios are 24-fold, 34-fold.
Hmm.
I'm going to jump in with a question, Kelly. I mean, the comments are so grateful to you, and people talk about how not just they've learned so much, but actually how excited and inspired they feel to do more, which is, I think, a hallmark of your work. So I wanted to ask you a question that's coming up in a number of the comments, which is about the lack of resources in our systems. Because, you know, you've found a way to be in the halls of power and to speak to what needs to be done. But I think many of us have the experience that even after we've identified patients who need treatment, the resources aren't always there. The reimbursement by the insurance companies, the number of inpatient beds, the number of providers who take insurance, all those things. And I wonder if from your experience, you have thoughts about these problems and how we as a society and as a profession can go about addressing them.
Well, I mean, as you said, I mean, we can't fix everything, but like I have kept reinforcing, this tool's contribution to that, to redirecting those very, very scarce resources has been a tremendous, help towards that terrible problem, right? And that's why I was saying, why do states and say we've lowered suicide again? Because for the first time, we're, making sense of those scarce resources by connecting only the right people to the care they need. The other thing is, things like safety planning, right? Which is the fantastic. And the first, that we usually lost people at the first crisis contact with these high intensity CBT, DBT, right? This is unbelievable. There's an app, it's very potent. So there are also these interventions, right, that can be part of the intervention toolkit that is quite helpful. And maybe we could Greg Brown is the other author of Safety Planning, and he's also an author on the Columbia and a very close friend. Maybe he could do another rounds for you too.
Yeah, that'd be great.
Great idea.
Yeah. Okay.
So I know there's other questions. I just don't want to forget. I want to tell you that you're all going to get these swag bags. We're delivering them
Wonderful.
to the hospital, where you're gonna, you see people all over the nation and beyond with these yellow clipboards.
Oh, those are fantastic. Yeah.
And keychains and mugs and bracelets. And, these are things that really help us elevate the movement. So on CNN, and Anderson Cooper, they're like, I wear my bracelet to remind me of the power of the protocol, right? I hope that when you go soon enough to travel somewhere, you're going to see every TSA guy with this bracelet on. So this swag is really, well, first of all, clinically, this clipboard people love. If you're in a submarine in the Navy, the engineer is going to have this. So you can imagine why this is great, but this stuff is really helpful. And we're going to have the cards and maybe the lanyards with your, for ask your colleague, all the cards, etc.
Yeah, that's phenomenal. And if somebody is not here at Silver Hill, how could they access some of that? Because all that sounds such terrific resource.
Yes. So they just, we have the email there.
Okay.
They just contact us, and we are, a full-time, full service partner. If you want to have, how can I get this to my system? How can I have help with a patient? We are here at your disposal. And I think that was some of the questions.
Yeah.
I mean, I was giving this to Yale last week to all the health services, right? And for the university, and today it's for Yale New Haven Health, right? So we're here to do this for anybody that wants it, essentially.
Wonderful.
I'll just add that for those of you who, as Michael said, are not already staff members here, you can email Jane Cullen, who's our coordinator, who sets up, and we'll make sure that we either get your information to Kelly, or we'll make sure you get your swag bag. So thank you, Kelly, for all that, because as you mentioned, a lot of the comments are about how do they get these resources, how do they learn more about it, how do they get the cards. And I think, like so many things, communication and clarity can save lives. So I wanted to sort of wrap up with one last question, and again looking at all the terrific things that people are saying. What would you recommend? I think a lot of the people online are working in the field. They're nurses, they're doctors, they're social workers who are out there, and they're not necessarily making the decisions for the entire organizations. But what can they do to be part of this movement that you're describing? What would you recommend that how they can support the work you're doing and move things forward?
It really is about communication. So there is not, as you can imagine, there's not an executive or leadership, whether you're a principal or the head of a hospital, who wouldn't go, oh my God, who doesn't want reduction in suicide, protection against liability, etc. So really, we love ambassadors. We love you to say, hey, may know about this, but look how we can optimize in our communities. It's funny, I said all police, and I went to give another talk to all the sheriffs in Connecticut, to the police chiefs. And, you still find people, that go, oh my God, I didn't know about this, right? So top-down policy, meeting bottom up community efforts. So that is completely how you can all be helpful. And we are so, so, so grateful for that.
Great.
Fantastic. Well, I wanted to say that, you've inspired me. I think you've inspired everybody who's listened to you. And over the years, you've inspired thousands of maybe millions of people out there. And we're so grateful to you for being here with us today, Kelly. I want to also thank Dr. Groth for being on and for leading the conversation. And I want to remind everybody that if you wish to receive continuing education credits, please complete the evaluation survey that will show up automatically as the webinar ends.
And I also just put my cell and email in the chat.
Great.
That was to everybody, right? Yeah.
Yeah, we'll make sure
Thank
everybody
you so
gets it.
much. Thank you for your generosity. Really appreciate it. Thank you.
Such a joy to have done this today.
Yes.
Well, that concludes everything for today. Thank you, everybody, for joining us. Thank you, Kelly. Thank you, Michael. And
Thank
see
you,
you again
everyone. Thanks,
next
Andrew.
Grand Rounds. Bye, everybody.
Bye-bye.